I'd like to thank the management of KBN Medical College and University for giving me opportunity to present my work. I also thank Department of Surgery and the organizing committee, Dr. Monitin sir, Dr. Devani sir, Dr. Bashir sir, Dr. Nand Kishore, Dr. Anup, and everyone. So next 20 minutes is going to be very interesting. It's going to improve a lot of life and how we change people's life. That's what I'm going to show in next 20 minutes. So what is the importance of breast? The breast is the most important external identification of femininity, and loss of breast can have a devastating psychological effects on the woman. A woman who has lost left breast through a cancer may feel self-conscious, insecure, inferior to other women, and she will be undesirable for men. So what is the ideal breast? So ideal breast is something where you can see here, the 45% of the breast should be there above the nipple and the 55% of the breast should be below the nipple. This is what looks an ideal aesthetic breast. So this is an ideal breast. Uh, Not everyone have the same breast. Breast comes in all sizes, all shapes, because all human beings are not equal. The same thing applies to the breast as well. So what we get is something like this. We get something like this and we have to do something like this. Our job is similar to an architect. Architect, you see, he gets a plain hall. The interiors are done by the architect. It's something like that. Our job is something like that. So what happens after mastectomy? So I always tell, probably this part of India or this part of Karnataka, not many people emphasize on reconstruction. But whenever the patient comes to us, when I ask them what is the primary reason of undergoing a reconstruction, they always feel that what happens after mastectomy is similar to what happens if a person loses his hand or upper limb. The same is a feeling. You imagine morning, you get up one fine day and you don't have your breast. So bad you feel, you cannot see your face or your body in your own mirror. That is how is a feeling. A person's losing breast, it is most devastating for that person. So the feeling is same as losing an arm or any other part of the body. So the patients are usually depressed. They'll not be able to wear their favorite gowns. They'll not be able to go outside parties. They'll not able to be found their femininity. This is the problem. So why breast reconstruction? The people most common answer is I have a long life to live. I want to leave it whole. I wanted once again to put the beautiful nightgown and fill it all out. I was gardening one day when I bent over, my prosthesis fell out. Crying, I picked it out of muddy water. Then the next day, she visited the plastic surgery. So the most common questions when the patients ask is who is the candidate? Will the breast reconstruction interfere with the cancer treatment or the detection? Are there some women who should not have reconstruction? Does the type of cancer make a difference? How does the adjuvant therapy impact on reconstruction? So the most common indication for reconstruction is anyone who have breast cancer and who have achieved the complete cure of the cancer. There we can do a reconstruction. In case of a toilet mastectomy, when patients underwent stage 4 cancer, where there is complete involvement of the chest wall, even there is a metastasis, in those cases we just do a chest cover. But other places, whenever the patient desires, we can do a breast reconstruction. So the goals of reconstruction is volume, that is to achieve a perfect size and projection, envelope to achieve a good shape and projection. Symmetry is very important to match the contralateral breast. And finally, we have to recreate the nipple areola complex. So comparison between the breast surgeries and the extent of resection. So in most radical mastectomy, the reconstruction would be skin graft or local flap required to cover the defect in case of a radical mastectomy. In case of a modified radical mastectomy, we can do a possible immediate reconstruction or a delayed reconstruction. And in case of a simple mastectomy, we can do a immediate or delayed reconstruction. Skin sparing mastectomy, we can do a immediate reconstruction. And in case of breast conservative surgery, usually the reconstruction is not required. So timing of the surgery is very important, whether to combine the reconstruction during the mastectomy or we have to delay it. Both have its own advantages and disadvantages. The immediate has the advantage that no feeling of loss of femininity, less self-esteem is maintained, body image, and less incidence of depression. In case of a delayed, that is indicated when the patient is needing a radiotherapy, because in radiotherapy can interfere in reconstruction, and most reconstructions are immediately following mastectomy nowadays, because as you see, the social media has played a huge role in increasing the awareness about breast reconstruction. So immediate reconstruction, there is a better breast symmetry that can be achieved, and more of original sensate skin can be preserved, and the breast remains sensate. Especially in the delayed reconstruction, the flap what we use, most of the times it remains insensate, and it is easier to preserve the inframammary crease. That is one of the important landmark in the breast, and that can be retained in immediate, but very difficult to re-establish. It can be re-established, but difficult to re-establish in a delayed reconstruction. So the patients who are undergoing additional cancer therapy such as radiation, in those patients we recommend a delayed reconstruction, and sometimes it gives an advantage that patient to consider the other options of reconstruction, and mastectomy scar is present on the chest that requires an additional surgery and recovery, and most of the times the secondary surgeries are very difficult because already there is a lot of scarring that has happened, and the patient has to undergo the second delayed reconstruction. So what are the options of breast reconstruction? So there are autogenous and there are alloplastic. So autogenous, there are these flaps, local flaps what we use. Abdominal flaps are tram flap, that is transverse rectus abdominis myocutaneous flap, that can be a single pedicle or double pedicle flap. These deep inferior epigastric perforator flap, superficial inferior epigastric perforator flap, and latissimus dorsi musculocutaneous flap. These are the local or free flaps that both can be used, and distant flaps like gluteal flap, superior blast, inferior blast, Rubens flap, lateral transverse thigh flap, that is tuck flap, thoracoepigastric flap, gracilis flap. These all require a microsurgical procedure. That is we need to have a microscope and we take out the flaps from the other parts. We use a microscope to anastomosis the in the either axilla or in the chest. So alloplastic, what we have a silicone gel implants or saline implants. So silicone gel implants we can fill with the saline, or it can be combined with the LD flap, or it can be combined with the tram flap. So we have a patient like this. The patient comes to like this. So what are the options? We can use a latissimus dorsi musculocutaneous flap, or we can use a rectus abdominis musculocutaneous flap, or we have some other options. Again, we have to sit with the patient. We have to decide. We have to give all the possible options what the patient has, and then we help them to decide what option they want. So the prosthetic techniques, the indications for this is usually the bilateral reconstruction, smaller breast molds with a minimal ptosis. There is a lack of adequate abdominal tissue due to previous surgeries. The patient is not willing for a additional scar on the back or on the abdomen, and patient requesting a augmentation in addition to the reconstruction. So what we do here is we immediately after mastectomy we place expander or a implant below the muscle. We expand it when whatever size we need, and then we reconstruct. The relative contraindication for prosthetic breast implant is patient unwilling to adhere to the follow-up, very large breast, very ptotic breast, and absolute contraindication is silicone allergy. Some people have a silicone allergy, implant fear, and previous failed implants, and need for a adjuvant radiotherapy. These are the absolute contraindication for the silicone breast implants. The expander implant reconstruction. So appropriate for the patient whose skin envelope is preserved, and that is the patient is treated by skin sparing mastectomy, and it can be immediate or a delayed. A permanent prosthesis is placed subpectorally and tension-free skin closure is obtained. This technique usually it has two stages. It corrects the skin deficiency, and it needs a multiple office visits. These kind of implants we usually have something like this. You can see these are the tissue expanders. We place it below the muscle. We expand using this port. We insert the saline. We insert the distilled water. We expand whatever size we want. Once the size what we want is expanded, then we place the silicone implant inside. This is the incision what we use, and we place the expanded. This is the final result that can be achieved. This is a pre-operative of a same patient, some patient having a malignancy, expander in situ after the placement of the implant. This is a final appearance after nipple areolar complex has been reconstructed. In case of a permanent expander, that is the implant what we place below the muscle that acts as an implant as well as expander, both. It acts as the same. That can be used. It has a special port. This can be removed after the adequate size has been achieved. This has an advantage of single stage, correct the skin deficiency, and this also needs a multiple office visits. So this is a patient with the immediate implant-based breast reconstruction. We have placed a tissue expander implant and expanded after multiple visits. Usually takes around 3 to 4 months to achieve a symmetry. The advantages of this is it decreases the operative time, no required of second procedure, no additional scars, good color match can be obtained, and no donor site morbidity. You might be knowing this lady, beautiful lady, many times, many years. She was the face of ideal aesthetic plastic or the ideal face. She underwent a double prophylactic mastectomy and implant-based reconstruction. She underwent 3 stages for implant-based reconstruction. She used expanders. Expanders were removed in 3rd stage, and permanent silicone implants were used. So coming to the transposition flap reconstructions, the options available for us is latissimus dorsi musculocutaneous flap and transverse rectus abdominis musculocutaneous flap. The advantages of this is it corrects the skin deficiency. The normal subcutaneous tissue has to be used. There is no use of foreign material. Longer operative time is needed after mastectomy, and it carries bit higher morbidity compared to the other techniques. In latissimus dorsi, this is a fan-shaped muscle in the back of the abdomen, and this cannot be used in cases where there is a thoracodorsal pedicle has been already damaged. So the indication for breast reconstruction using LD flap is a smaller breast, minor breast ptosis, abdominal donor site is not available due to scar or lack of tissue, salvage of previous breast reconstruction, and absolute contraindication for this is previous thoracotomies. So this is a lateral latissimus dorsi flap, and this is a skin pedal that can be used. So once we harvest, we move it in the breast, and this is a sutured line. Let us see some of the practical cases. This patient had a CA breast, stage 2, and she underwent a MRM, axillary lymph node clearance, and latissimus dorsi flap was used along with the skin paddle, and these are the drains. Sorry. And this is the final appearance, well settled flap. Another patient who had a fungating growth, LD muscle was harvested from the back. This is a skin pedal that was used, and skin pedal sutured to the defect. Now let us see about TRAM flap, that is transverse rectus abdominis myocutaneous flap. The indication for this is a large breast, the breast which has a ptosis, and the contraindication for this is a previous abdominoplasty. So pedicle TRAM, what we do is we based on superior epigastric vessels, we take the muscle along with the lower part of the abdomen, and along with this pedicle, this muscle, this much part of the abdomen has been taken, and we use it to reconstruct this part. Here we cut out this part of the vessels have been cut. We retain one side of the vessels, and once the abdomen is closed with the abdominoplasty, like we pull down the abdomen. I'll show you the practically how we did this. We did way back in 2017 when I just came back from US. This patient had a mastectomy. After that, she was very depressed. She came to me. She wanted a breast reconstruction. She had a very lax abdomen, 3 pregnancies she had. So we used a TRAM flap here. This is the marking. We used a contralateral rectus abdominis muscle along with the pedicle. This is a marking what we do, and This is after the harvest of the tram flap, which sutured the rectus abdominis with the other side of the rectus abdominis and other para abdominal muscles. And this is after the reconstruction immediately on table. You can see very nicely done abdomen. Like, who doesn't want abdomen like this? See, this looks youthful. This looks wonderful, right? So very well settled flap. This is immediately on table. This usually settles. This is after 2 weeks and this is after 6 weeks. The patient came to us after 6 weeks. She said, just wow, wow, like she cannot believe she had a new lease of life after that. And abdominal suture line, it is completely hidden in her panty lines. So absolutely youthful abdomen. So who doesn't want like this from here till here? Everyone wants, but it's not been offered. It's not, the patient doesn't know that this can be achieved. If we offer, who doesn't want this? So another patient who had a CA breast, same tram flap was planned, tram flap was harvested, contralateral flap, the reconstruction, this is after him. Another single pedicle tram flap, post-op immediately. So if we have a microscope, we can do something called as free tram flap, where we disconnect the deep inferior epigastric vessels and we use the either transverse arteries or internal memory artery to connect the superficial epigastric or deep inferior epigastric vessels, and this is a free tram flap. The same, the incision, everything remains the same, only that we disconnect the flap. The entire flap has been disconnected. So for evaluation of these flaps, we need to understand first whether the vessels are very nicely, which vessel is prominent. To see that, we need a CT angio for evaluation of deep inferior epigastric artery or superficial inferior epigastric artery. Here you can see that is superficial inferior epigastric artery, and this is a deep. Deep is very prominent, so we have to use a deeper one. The primary reconstruction with the DIP flap, the patient had a CA breast, the marking of a DIP flap, this is a harvest along with the vessel. Here the advantage is you can spare the other side rectus abdominis muscle so that the abdomen still remains tight. This is after the inset of the flap. Another patient who had a mastectomy, delayed reconstruction of the breast, DIP flap was done. This is immediately after inset, and this is immediately after the closure of the abdomen. DIP flap, here no muscle, no sheath, only perforator. You can see this is a perforator. This is a perforator. This is a skin and this soft tissue. That's the only thing. Now we don't use muscle here. So the advantage is the abdominal strength remains the same. The advantages of DIP flap, rectus abdominis muscle is saved, rectus sheath is saved, primary closure is obtained, so no mesh is required. Another few more techniques, because the evolving medical sciences, gluteal flaps have come, that is superiorly based or inferiorly based. Here superior based is preferred because the amount of tissue what we get is more, and it doesn't bear the pressure on the sitting position. Internal memory arteries are the most commonly used for recipient, and the vessels where what we use is the branches of internal iliac artery. Based on those branches, we use the free flaps. So this is a S-gap flap, that is a superior gluteal artery flap based on internal iliac artery. This is a flap what we take. We use the vessel, we bring it to the abdomen, close the defect, anastomosis with the internal memory artery, and this is a primary closure of the muscle where we take. Absolutely hidden inside the bikini line. So this is a S-gap flap. Patient had a CA breast, mastectomy was done. Then we used the superior gluteal artery flap. These are the flaps, both the sides, and reconstructed. Another, this is an inferior epigastric artery flap, where this comes inside the cleft. So after mastectomy, this is a defect. This is a flap what has been taken, and this is after reconstruction. There is another, after many people, even after wearing those bikinis, monokinis, as they are getting smaller and smaller, they wanted something which the entire scar has to be hidden. So this led to an invention of a transverse upper gracilis flap. This flap has a skin, fat, gracilis muscle of the inner thigh, and it constitutes the transverse upper gracilis flap. The incision line is within the groin crease. The skin and the fat can be made in the cone shape. That's the biggest advantage. Used in patients where the patient's abdomen cannot be used, in the small volume reconstructions where the breasts are really very small, and it has a most superior cosmetic outcome in the present reconstruction of the breast. The nipple can be reconstructed in the same setting. So this is a tuck flap. Here, this is how it is based. We use a gracilis artery along with the gracilis muscle, and skin and soft tissue has to be taken. It is brought to the chest, anastomosed with the internal memory artery, and practically this can be molded. It can be molded in any shape, breast shape, and nipple can be reconstructed in the same setting. This is a reconstructed nipple in the tuck flap. So this is on table result, and this is a final appearance. So coming to nipple reconstruction, our reconstruction doesn't stop at just breast reconstruction. Giving volume doesn't stop that. Some patients, they even want a normal appearing breast as well. So in those patients, we offer something called as nipple reconstruction. The position of the nipple has to be judged properly for the aesthetic appearance, and usually it has to be delayed 3 to 6 months after complete reconstruction of the breast mold, because there is some amount of inflammation, there is some amount of scarring, fibrosis that is going on in the new flap. So methods, there are many methods. Most common is locally flaps we use, or we can use a opposite sided nipple graft, skin graft from the labia, or it can be used from the inner thigh. For giving elevation, we can use a cartilage graft. Nowadays we are using fillers, injectables, hyaluronic acid we are using for giving an elevation. So there are these many local flaps are there, like skate flap, modified skate flap, star flap, but I commonly follow is star flap or a C flap. This is something called as a skate flap. We place an incision, we give a elevation like this, and suture it. We do tattoo. There are medical tattoos. We do tattoo for areola reconstruction, and this is the final appearance. This is a DIP patient with the NAC reconstructed. Both appears almost similar. Hardly, if you see from the distance, you can hardly make out that this breast has been reconstructed. Areola reconstruction in another patient who had underwent mastectomy and breast reconstruction. So we can use a graft either from the opposite side, or we can use it from the labia. We can make areola using the graft. So no breast reconstruction, is it an option? Yes. In few patients, women who choose, it can be, it cannot be. I mean, we can just leave it like that. As Hatti sir said that in our patients, many of them, they don't want to get reconstructed. Yes, it's their own choice. Again, age of the patient, stage of the cancer can play a very important role in breast reconstruction. There are available external silicone prosthesis that is available. A woman can choose that, something like this, external prosthesis, they can keep it their bra, and they can mimic that the breast is fuller. But rehabilitation, breast reconstruction following mastectomy is not to restore the function, but it doesn't need to be. The point of the breast reconstruction is to make the patient as whole again as she was before the breast mastectomy. So the breast reconstruction, including the revision balancing procedure, has to be viewed as rehabilitation and not as a cosmetic. That is the reason why nowadays insurance has started covering breast reconstructions all end to two. Even including the implants, they are started covering the breast reconstructions. The end result is to make the woman very happy. The starting I showed you a depressed woman. You imagine one fine day you get up in the morning and you say that you don't have a breast. How it feels? Depressed, right? So at the end of the day, achieving a happy woman is through breast reconstruction. So the future of reconstruction, there have been a lot of innovations in last 1 decade. People have started using robot to harvest the LD flap. There have been extensive use of acellular dermal matrix. Lymphovenous anastomosis have been offered in a primary mastectomy patients to prevent lymphedema. Stacked flaps for breast reconstruction, that is use of multiple flaps to reconstruct the breast, achieve a normal volume, have been recommended in the last few years. So this is a harvest of the LD using a robot. Here, these multiple ports have been used. No use of this long skin incision have been placed. So this is a harvest of the LD through a robot, very small incision in the axilla, and this is a result after reconstruction of the breast using a LD flap harvested through a robot. So to conclude, breast reconstruction may be one of the most significant female surgeries of this era, and it has been increasing in last 1 decade. It may lessen the fear that contributes to women's avoidance of medical evaluation of the breast problems. Immediate reconstruction is favored because studies have documented no increase in oncological risk, no delay in adjuvant therapy, better aesthetic outcome, less depression, and more cost effective compared to a delayed reconstruction. Autogenous tissue provides superior results, but at the cost of a donor site. I thank Department of Surgery and Organizing Committee for giving me opportunity to present my work. And if any doubts, we can discuss. Thank you. Thank you, Chairperson.